Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and increasingly about other infectious pathogens out there. This is the week of November 29th and I guess first couple days of December, so happy holiday season, everyone. Lots of questions this time and focusing actually on some of the additional immediate challenges that I think everyone is still facing, that being the onslaught of respiratory viruses, especially RSV, but now increasingly influenza A/B, re-increase in COVID-19 cases in kids, on top of the existing rhino/enterovirus, adenovirus, etc. and so forth. So our first question for something completely different, and this is quite refreshing, thank you for this, is has there been an increase in mosquito-transmitted viruses or even mosquito-transmitted diseases in Arizona, including dengue? So this question comes from the identification of a case of dengue in Phoenix, specifically Maricopa County is where it comes from. Importantly, that individual most likely acquired their dengue infection while visiting the Philippines for an extended period of time. That said, in response to identification of that case, the Maricopa County Health Department, as with other health departments in the state, performed a mosquito capture and mosquito testing to identify what mosquitoes are out there and also what the mosquitoes that are out there might be carrying. First and foremost, and this is important to know, is that there is a fairly decent number, or there were a fairly decent number, of the Aedes aegypti and Aedes albopicti, or albopictus. Those are the two Aedes mosquitoes known to carry chikungunya, dengue, and Zika virus. Also, those same mosquitoes exist across the border in large parts of Mexico and, of course, down further into Central and South America. So it's something that we've been tracking for quite some time, has been the presence of the potential vector for mosquito-borne viruses coming up from the Americas below the United States of America. And unfortunately, Arizona has both of those mosquito vectors quite prominently through most of the state, excepting perhaps the upper elevations around Flagstaff. So that part is not a surprise. Known about it, it's been there probably for at least the last 10 years or so. What was a surprise, unfortunately, is that they identified a single mosquito in that collection in response to the dengue patient, a single mosquito that had dengue virus in its bloodstream. So that suggests that either our patient who may have acquired dengue in the Philippines was then bit by mosquitoes locally, and that dengue has now entered the mosquito pool in Arizona, and or that it happened spontaneously, which also is a definite possibility. Not likely that the dengue in Maricopa County came from Mexico, because the Aedes mosquito is what is known as a wetlands mosquito or a river plain mosquito. So typically doesn't travel much more than 50 meters from its site of hatching from the larvae, and it typically activates as the waters or the rains come through and our floodplains start to become moist. So more likely than not, dengue was introduced into the Maricopa County mosquito pool by some other mechanism, then transfer up from Mexico. Regardless, that specific fact that dengue has been found in Arizona is perhaps a bit of a warning that we might yet see more cases emerging, perhaps not now that it's cold, but in the next mosquito season, which won't take too awfully long to come. So far, no screening positives for chikungunya and no screening positives for Zika. On the other hand, this has been a much more robust year for West Nile virus. Different mosquito, that's the Culex mosquito, and that also is quite prominent throughout Arizona. And there have been West Nile virus cases, most especially in adults and older adults throughout the state, including deaths related to neurologic complications of West Nile virus. While there have been several pediatric West Nile virus patients, so far, that has not been a significant majority of the cases, mostly affecting people who are older in age, are somewhat infirm, experiencing life with disablement, and or are shut-ins. So, there has been a increase from the West Nile virus perspective and an important single case of dengue in the state. So far, none of the others, but just heads up that this may be, the next mosquito season may be a little bit more exciting than this past year has been. Next question then, turning to COVID, is can we talk about the recent study that shows COVID-19 may increase the risk of seizures in children? So there actually have been, or has been, a fair amount of literature beginning even 6 months or so after the start of the pandemic worldwide that shows an increased risk of seizures. Several more recent articles, especially one published in the last half year or so in Pediatrics. And I'll talk about that study first. So that is a multi-center study that looked at reports from 52 children's hospitals, so freestanding children's hospitals in the United States, that contribute to a large database that is accessible to researchers. So in this case, just over 15,000 pediatric COVID-19 patients from 2 months through 17 years of age, so pretty typical range, were surveyed, and it turns out 7% of those patients had evidence of a new neurologic complication, meaning regardless of pre-existing seizure history or neurologic history or living with cerebral palsy or something like that, these were children that developed a new neurologic complication, a majority of which were seizures in association with fever. So febrile seizures followed closely by non-febrile seizures and then also by encephalopathy. Those were the top 3 neurologic complications seen in children. Interestingly, this study was surveying during which Delta variant was the predominant variant in the United States. And so the suggestion was, well, that seemed to have been associated with Delta variant, perhaps more so than wild type variant. And how do we know what's happening with Omicron? Unfortunately, there have been other studies subsequent to that, much more focused, so pilot studies or case series, including one published in the journal Epilepsia, how's that for a cool name, that looked at a case series of 16 patients that were surveyed because the authors felt they represented an increase in seizure incidence. So these were patients that had complex seizures, a third of whom did have a history of prior seizures, but seizures had been well controlled by anti-epileptics. So new onset of complex seizures, and these patients were during the Omicron surge. So combining those 2 studies and multiple other ones in individual case reports, case series, and sort of epidemiologic modeling, there does appear to be indeed an increased risk of new onset seizures, which may be complex, in children experiencing COVID-19. And that is more so than has been reported in the adult population and certainly the older adult population. So that's unfortunate. And you can also then ask an important next question, why? We don't have a clear understanding of that other than the wealth of research, a wealth of discovery suggesting that the impact of SARS-CoV-2 on the central nervous system is not a direct neuronal attack on the nerves themselves, but on the surrounding supportive tissues and an upregulation of the microglial cells so that you create a localized inflammatory reaction. So basically you're creating, or instigating, I guess is perhaps a term, through infection with SARS-CoV-2, localized focal inflammation causing a focal encephalitis. It stands to reason then that that localized inflammatory process might serve as a focus to start a seizure, and because that effect would be generalized throughout the brain, a focal seizure could rapidly generalize to a complex generalized tonic-clonic seizure. So that is the hypothesis, and certainly that has been supported in accompanying editorials. Why more is so in kids than in adults? And it could be that, and especially younger kids, have less mature control mechanisms or sort of reflex negative inhibition of an inflammatory reaction, and thus they may have more pronounced inflammatory processes within the brain. I'm not sure what kind of evidence to call this, but it's interesting to note that in the pediatric series, several of them that have been published, impact of steroids as part of the treatment of the acute COVID-19 seem to have an important and specific treatment effect in making the seizures easier to control. So those children who actually were having continued seizures despite initiation of anti-epileptic therapy had a much more rapid response to those anti-epileptic drugs if they received steroids versus those who did not, and were more likely to stabilize and discharge from hospital in a statistically significant fashion if they had received steroids. Makes sense, right? Because steroids, in addition to effects that we think of them for respiratory issues and the positive effect on COVID-19 lung, would also inhibit that robust inflammatory reaction at the level of the central nervous system, perhaps decreasing the swelling, decreasing the inflammation that might be triggering seizure foci. So there you go. There does appear to be, based on a collection of data, an increased risk of seizures, new onset seizures, and lowering of seizure threshold in those kids already with epilepsy, in those who also have COVID-19 disease. All right, turning then to the current situation with the overwhelming flood of respiratory illnesses. What are the updates on the respiratory viruses out there? So, our dear friend, respiratory syncytial virus, RSV, has continued to be causing a significant amount of morbidity and, unfortunately, in some cases, mortality. So, significant hospitalizations, significant floods to acute care, portals of entry, so emergency departments, urgent care centers, all of your offices, I am sure, especially if you have an urgent care scenario. And those numbers have continued to be quite robust. Looking at national data, and this is through the CDC, as well as several independent and objective data monitoring organizations, Arizona, unfortunately, right now, this week as I talk to you, is number 1 in the country for hospital bed occupancy at 98.8% of hospital beds. Importantly, that's 98.8% of available hospital beds that are licensed for pediatric admission. And that includes general pediatric beds and pediatric ICU beds. All of them are completely filled, and I'm being careful to distinguish available beds because there are, as you'd imagine, staffing issues as well. Most hospital sites are struggling to maintain their nursing staff due to, of course, burnout, fatigue from the COVID-19 pandemic, and illnesses, right? We're living in a cesspool of viruses out there, of course. Many of us are also going to get virus X and be unable to work until we can come out of isolation. So it's not every physical bed in the hospital that is filled, or in the state that is filled. It's the staffed beds are almost completely filled on a daily and nightly basis. So that is significant. And RSV currently is felt to be the most prominent respiratory virus contributing to that. However, many of the children being hospitalized are RSV and. So RSV and parainfluenza, RSV and SARS coronavirus 2, and many of the other respiratory viruses out there are causing co-infection. Which came first? Hard to say. It may be, of course, that the RSV component is what is triggering the respiratory failure, the need for oxygen, and somewhat surprisingly, because this is not a typical pattern for bronchiolitis, a fair number of the children requiring hospitalization are having a reactive airways disease component. So they're actually presenting with wheezing, and they're responding, believe it or not, to bronchodilators, and also in some cases to steroids. So behaving like a more typical wheezing-associated respiratory illness, which is not our typical experience with RSV bronchiolitis. Be that as it may, there are a bunch of multi-infections out there. We just recently admitted to my institution a quadrifecta of adeno, RSV, rhinoentro, and parainfluenza. So, all 4 viruses present in one respiratory specimen from a patient. Obviously, that's a whole bunch of disease going on out there. So, Arizona is number 1 in the country in terms of bed occupancy. That would suggest, of course, that the burden of patients presenting to portals of entry, especially emergency departments, is extreme, and that is true. Obviously, I would imagine if anybody is working in an emergency department or knows somebody who is, or you've attempted to send a patient into the emergency department for evaluation for something other than a respiratory illness, you know just how terrible things are. Wait times of 6 to 8 hours. This is like pediatric version of COVID-19 in the early days. And that, in fact, has been so named coming from Dr. Fauci and others in the federal government. So, yeah, we're bad. Arizona is very bad. However, as a slight, I hope, hint of hope, we appear to have peaked with our numbers of RSV cases based on CDC data, which comes to the CDC from Arizona Department of Health Services and from Arizona Department of Health Services, from the local county health departments and reporting structures, and also including reporting from commercial laboratories. So it's a fairly robust data set, and countrywide, RSV cases peaked, plateaued, and are now decreasing for the past several weeks on the East Coast, especially the Southeast, but also on up into areas like New York, Pennsylvania, and further north than that. And that decrease has been noted actually spreading to the Midwest. So Illinois, Missouri are all reporting decreasing numbers of cases of RSV. If we then look at Arizona's data, and this is available to you if you wish to search cdc.gov or several other reporting structures, it would appear that we peaked peaked perhaps even last week, so the week of Thanksgiving, and the predictive modeling suggests that our numbers are downsloping even this week. Obviously, it's way too early to tell, but perhaps the next time we speak on the podcast, we'll have good news that our numbers truly have started to decrease. And that would be fabulous news, because we really cannot continue the level of strain on the healthcare infrastructure as it currently exists. So RSV absolutely out there, hopefully has peaked, perhaps coming down. In that setting, influenza A and especially influenza B actually has now started to make its evil presence known. So starting to see increasing numbers of cases of positive respiratory panels for influenza A and B. SARS coronavirus 2 unfortunately has increased again in Arizona to the point where we're in the top 5 states in the country in terms of current attack rate, hospitalizations, and now unfortunately increasing deaths related to COVID-19. So at least in Pima County, where I'm speaking from, and several other counties in Arizona, it is now at extreme or high level of community presence, and we're going back to the bad old days of needing to put masks on in public areas and certainly on internal sites. And in fact, several symposia that had been scheduled and holiday parties, I'm sure, for the first part of the month are now being postponed or canceled. So all that is still there. Rhino/enterovirus is still sort of a steady stream and will probably continue to be so throughout the winter. And so what we're really looking at is the seasonal surges of RSV. Upcoming will be influenza, and along with that, also increasing numbers of parainfluenzas, causing, of course, our friend croup. So that is sort of the epidemiologic status of things. Again, epidemiologically for RSV, talked about this last time, it still yet appears that it's targeting an older age range than we typically see hospitalized. So we're all used to the, infants up to 1 year of age being most especially affected by RSV, causing atypical bronchiolitis, coming in for nose sucking or snot sucking, depending on what you like to use, and oxygen delivery, and then sort of being stuck in hospital for days to sometimes weeks with that dwindling O2 requirement. However, this current RSV surge has been quite notable for affecting ages 1 through 4 years, with, as I noted before, a reactive airway component and also just sheer plain hypoxia, hypercarbia, and need for non-invasive ventilation. So again, that makes sense because we spent the last now almost 3 years, 3 years actually, if you look from when the pandemic started in China. The last 3 years, sheltering in place and hiding behind masks mostly, so that today's kids, especially up to age 3 and maybe even age 4, are immunologically naive in terms of exposure to most of those respiratory viruses. And certainly infants in the last couple years have been born to moms who themselves had not likely experienced a respiratory illness during pregnancy, so the infants do not have significant transplacental levels of antibodies. So it's a whole bunch of kids out there who are at risk for any of the respiratory viruses, including, unfortunately, RSV, and then are developing significant disease. So the overwhelming burden of RSV disease and other respiratory illnesses has not gone unnoticed by the AAP, of course, and certainly it's not gone unnoticed, sorry for the double negative, by all of us who are boots on ground trying to stay afloat and take care of kids. So the last question is, can I review the major updates in the AAP's new interim guidance on RSV, sort of the surge for RSV, and what are the resources? So if you wish to get a copy of this, again, it's very easy to search through the AAP website, or you can even just search like AAP RSV surge recommendations on our dear friend Doc Google. It'll send you right to that document. But I'm going to summarize basically what the major recommendations are from the AAP in terms of the RSV surge. And I'll start with the official language. The overall goal of interventions right now is to maintain uninterrupted care of children during the respiratory virus surges by increasing our capacity for emergency readiness on a day-to-day basis. Makes sense, right? And none of the recommendations, by the way, are ground or earth-shaking. I think all of us could come up with them on our own. It's just nice to see them in one document. Overall, the benefit of the recommendations from the AAP are to increase our operational readiness, for the known variations in patient volume and also acuity, and basically allowing our general practices and community hospitals and children's hospitals to have surge capability. What does that mean? Well, the first and the most important goal, of course, is to protect the delivery of routine pediatric care even as we are inundated with this surge of respiratory illnesses and RSV. Meaning, focusing as best we can on protecting routine vaccinations, providing mental health care and referrals for mental health care, providing some specialty referrals as they're necessary, and even trying to protect elective surgeries that are important for the health, the routine health of children, as with any time of year other than right now. And knowing that all of these are going to be affected by resources and office space and hospital bed space and OR space and, for that matter, subspecialist fatigue, et cetera, and so forth, the secondary goal behind the first is to prioritize delivery of that routine healthcare to those patient populations who are most marginalized or under-resourced. So absolutely, the child living with complex health needs is going to be a top priority to try and protect them in terms of their routine healthcare, but so too those children living in parts of the state that are marginalized, living in traditional housing, decreased transportation, decreased access to preventative healthcare visits. All those are our children that, as best we can, would wish to prioritize to receive that routine care. Following that, the recommendations go into staffing models. So knowing that we're already facing high degrees of staffing turnover, whether that's nursing staff, front office staff, MAs, PCTs, phlebotomists, I mean the whole nine yards, anything and everything that you might employ and deploy in general practice and in the hospital setting already has been experiencing high turnovers just from burnout, fatigue, etc. from the last 3 years. So new recruitment, of course, is a significant component of the recommendations themselves. But it's hard to recruit when there isn't a huge active source of pipeline other than the current ones. So nurses completing nursing schools, getting their clinicals done, getting licensed, and then ready to go. So one possible model, and I'm going to use the corporate term, is to upskill nurses that may have some pediatric experience and are willing to then sort of cross boundaries and care for kids, even if they are typically deployed in an internal medicine role. But if they have comfort with kids and can learn through a brief orientation, or maybe not so brief, then that is one way to create new skilled nursing staff who can help us out in all the levels or sites of healthcare delivery. The other part of the recommendation, and this is perhaps a bigger one, is that knowing that we are all struggling to maintain full staffing models, just as with COVID-19, we need to modify the quarantine or isolation of staff members who have become infected. Probably recall this from the whole debate in the CDC's recommendations, you need to have 14 days of isolation after infection with COVID-19, which dropped rapidly to 10 days and then to 5 days as more data became available, and also as there are a whole ton of healthcare providers at all levels who were stuck home even if they were no longer contagious or only mildly contagious. So here's where things get tricky. At what point can you bring a healthcare worker back to healthcare delivery after they've been infected with the flu or RSV or COVID-19? And the thought is, if they can safely and effectively wear their mask and, of course, practice excellent hand hygiene, etc., and are at least no longer febrile for at least 24 hours, even if they still have the runny nose and the respiratory symptoms, they could potentially and safely come back to practice, because in their absence, the practice is going to close down. So I think all of you are encouraged by the AAP to look at your current isolation and staff quarantine models and loosen them while still being as safe as possible, but understand that the febrile person is most likely to be contagious. Give them 24 hours of being fever-free, and then if you got to have them back, invite them back. So that, I think, is perhaps the most dramatic of the recommendations from the AP, and I'm interpreting then, of course, they're careful not to say bring healthcare workers back, 2 days after developing RSV. They know we still need to make a safe determination on our own need level and comfort level. Next recommendation, maintain vigilance of infection prevention. Great big fat duh there. It's like, I don't want to get sick, so of course, making sure that masks are on and effectively on in the outpatient setting. Absolutely, most hospitals, and certainly the one I practice in, still have mandatory masks for all people inside the hospital walls. That is still, I think, a very important thing to do, but also re-emphasizing hand hygiene technique and putting in supplies of PPE, such as making sure that we have enough gowns and the gloves and the masks and everything else, so that everyone, patients and staff included, can practice safe infection prevention in clinical space that we're working in. And then I think also critically important is to support, and this is sort of the final major general recommendation, support the mental health, wellness, and resilience of the healthcare workers. It sounds like a no-brainer, but I think being mindful and purposeful about creating wellness events like, all right, hey, we're gonna order lunch in for the office staff, on Taco Tuesday or Happy Friday or just whatever it happens to be, or doing something nice. And perhaps doing that on a more regular basis, or even introducing staff yoga or mindful meditation for 5 minutes at the start of the clinic day. Something like that, just as a very deliberate, mindful approach to let everyone know that their wellness is important as well, and just trying to keep everyone fired at all 6 cylinders if they've got six to give, and keep them coming back. A couple additional thoughts for those of us working in an ambulatory setting, so that this, by the AAP, primarily means primary care practices, but also extends to sites that provide urgent care and even, in fact, emergency departments. The major recommendations here are to look at patient flow and throughput. And this certainly has been looked at in my institution. Can we triage early, and while triaging, start putting in orders for management of the patients, that those who are going to be perhaps positive for RSV and mildly sick can be rapidly triaged to go home with, anticipatory guidance and not have to take up an emergency department bed for further evaluation if they're still likely to be discharged. So looking at triaging, looking at pre-screening for symptoms, looking at ways perhaps to bring sicker patients rapidly back to a safe part of the clinic space, and here again, designating sort of the clean and the dirty, I'm not sure what else to call it, but parts of the clinic for those who are there for routine preventative healthcare visits, who are not sick, not infected, not febrile, and then a part of the clinic that is sort of tasked for those who have viral symptoms, and in this way trying to avoid prolonged mixing in the waiting room or etc. And it may be time, if one has not already done so, to return to the days of pre-screening by phone for the parking lot. So once you arrive, please phone in. We're going to ask you over the phone what are the symptoms, and if there are symptoms, then stay in the car until we come to get you and bring you straight back to a sick room, if you will, for further evaluation. So all of us are encouraged to look at our portals of entry, look at our entry process, look at our patient processing, if you will, to try and make things as efficient as possible and as safe as possible. And including, again, I think a fair number of us have continued to use telehealth as an outreach to try and keep the sick patient at home, if at all possible. But it may be that as we just run short of staff and rooms and energy levels, that increasing numbers of anticipatory or preventative healthcare visits that don't need interventions such as vaccines can be done by telehealth. And certainly referrals to screen for mental health concerns and referrals for resources there may increasingly be done by telehealth as well. So I think perhaps then the final global recommendation, especially for ambulatory settings, and this really applies everywhere, is to increase communication and outreach to our patient population and perhaps even to our communities. So I'm now filming Instagram videos. How cool is that? I've gone from writing a blog to now doing a podcast, and this in my mid-50s, like, wow, this is cool, new things to learn. How fun is that? And now doing short snippets of Instagram videos educating the community about RSV. From the, most children with RSV don't need hospitalization, don't need to come to the emergency room, and here's what to look for to identify respiratory distress and a need for further evaluation, to the most kids with RSV benefit from having their nose suctioned out, and here's how to do that, and here are the different techniques. And then even yesterday filmed one about the fact that adults can get RSV and thus be contagious to their kids, and unfortunately contagious to work environment and to the healthcare setting if they bring their kids for evaluation for something else. So communication via social media to educate our population about RSV, about isolation, about who needs to be seen when, is both educational but also a way of sort of showing the love, like, hey, this is your community pediatrician reaching out to you, trying to keep all of us healthy, and we all do better when we all do better. Something along those lines. So communication with patient populations and the community is certainly strongly supported by the AAP, and also ongoing communication within and among our own clinic staff, and also sort of portals of entry if we have to escalate care. So getting a sense, if possible, what is the status of beds, what is the status of the emergency department at our referral hospital, and supporting those individuals who are working there and saying, okay, hey, we know you're hurting, what can we do to help you other than to minimize the number of patients that we have to transport. Obviously, the sick kid has got to be transported, has got to be assessed, and that's without debate. But not every child who may have had fever for 3 weeks has to be sent to the ER for evaluation. What can we do to evaluate as an outpatient setting and to minimize the burden on those hospital beds, which are so critically under-resourced? For those of us who are working in community hospitals and or refer to a community hospital, a lot of the same things apply, because they're also the community hospitals that may or may not be really well set up to care for pediatric patients and may or may not have licensed pediatric beds, yet are being asked to do initial care for pediatric patients, helping those providers working in the community hospitals become more educated about pediatric care. I think it would be not appropriate to assume that a physician working in a community hospital is an expert in everything related to pediatric acute care. Most of their training is going to have been for internal medicine, perhaps internal acute medicine, and may or may not have had much in the way of pediatric training. So making oneself available for consultation to that provider who may have one of our patients in their emergency department, like, hey, I'm sending that patient to you. Here's typically what we would do in the pediatric emergency room. Is that something you're prepared to do? And just trying to be there as a resource for them when they ask questions or have consults as well. And then finally, for those working in the children's hospitals in the state, knowing that, yes, you are overburdened and overworked and all the other things, and that everybody's here to try and help us get through this and to work together. In no way should one feel, I don't know, persecuted by like, oh, there's another admission, holy cow. It's like by the time the kids reach to the children's hospital doors, clearly they are sick enough to require further expert evaluation. So I think all of us trying to work together to get through this with an end in sight in terms of RSV, and then seeing what happens with our flu season, maximizing routine vaccinations and regular preventative health care, including mental health care, especially for our patients, and maximizing self-care for ourselves has all got to be critically important. So that is sort of the summary of the AAP's recommendations, and I think that's just good talking points for all of us as we move forward and continue to keep coming back, as the saying is, to do the right thing and care for our patients and care for each other. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona and a whole bunch of other things, or to learn how to become a member, please visit us at azaap.org. And with that, once again, thank you all for tuning in, for listening. Hang in there, keep coming back, take care of yourselves, and know that we all appreciate you. Thanks again.